We drop so many social norms when we come into the hospital for some reason, and we just rush up to people and start touching them.
Yeah.
And I'll demo it in class. I'll rush up to somebody, and I'll go to reach out to them, not touch them. I'm like, how would you react if you're in the park or you're at the mall and someone just started touching you without your permission?
Hey guys, do you work in emergency medicine? An absolutely crazy and intense environment where you see things every day that a regular person doesn't see once in their entire life. You feel burned out, unappreciated, like there's no one you can talk to about the things you are struggling with? Well, you are not alone. I have a bunch of real professionals with real stories here with me today that can relate to your struggles. I've struggled with burnout, discouragement, and frustration at many times, and I still struggle with it. My name is Aaron. I've been in emergency medicine for 15 years as an EMT, paramedic, and now emergency medicine PA, and I am the host of the Practical EMS Podcast. Everything you hear today from myself and my guests is opinion only and doesn't represent any organizations or companies that any of us are affiliated with. The stories you hear have been modified to protect patient privacy, and any resemblance to real individuals is coincidental. This is for educational and entertainment purposes only and should not be taken as medical advice nor used to diagnose any medical or healthcare conditions. Well, sweet. Thanks for coming in, Josh.
Yeah.
Can you just, for everybody's information, just explain what you do, kind of what your background is, how you got into it?
Yeah. So simply put, like 20 years in public safety, ranging from Air Force security forces, a lot of time in healthcare security, but some time in youth corrections and even behavioral health services out in the community. So as of right now, last couple of years, I've been the Southern Region Crisis Prevention Instructor.
Okay.
So teaching a certain line of content there.
Yeah.
Mostly folks, de-escalation. And, of course, in the ED, sometimes we need physical interventions if they become a danger to themselves or others.
Right.
Right. So, yeah, it's kind of my trauma-informed job now. Definitely.
Yeah. One reason I wanted to talk to you is just because this is a topic that comes up a ton just on the podcast in general. Like the ER is a very unique setting. We deal with all kinds of aggressive behaviors from patients. A lot of times it's alcohol, it's drugs, even occasionally when they're just really not happy with the care and they don't understand kind of the limitations of the ER, and like even, folks that are addicted to opioids and we don't treat their pain adequately, or we say, hey, this is really not an appropriate reason to give a narcotic to you for this particular thing you have going on. And that really riles people up. So even the patients that aren't psychiatric or on, intoxicated or on drugs, even those patients escalate on occasion. And regardless of what you do in the ER, down to the techs, the EKG people even, you have to have some level of ability to de-escalate people and know how to talk to people, because a lot of times they're just not happy with our care. They don't have anything emergent going on. They're going to go home. They're not happy with the lack of an answer. And even in those small interactions, you have to learn how to talk to people to explain, like, we don't always get a clear answer. We're here to make sure you're not dying and make sure that they're content at least with that answer. So that's why I thought it'd be an interesting discussion, just because it's pertinent to everybody, not just security. Even at the clinician level, we need to know how to de-escalate people, and we get no training in that. Medical school, PA school, they don't teach you how to talk to people. They don't teach you how to de-escalate people. And, and it's not the patient's fault. This is often the worst day of their life. They don't know what's happening to them. They don't understand the ER. So not that it's their fault in every situation, but we need to know how to talk to people, on the worst day of their life, or what they've perceived as the worst day of their life. So
totally. And I'm excited. I'm hoping we are exploring opportunities. Some of our heads of department come out of the ED, including our docs, right? Yeah, they alluded that to us, like, in all their years of education, possibly a decade plus, they did not receive anything like my course. So, we're hoping to explore opportunities there, because that's huge. Yeah, sometimes I've had docs start code grays, or, just because it's how they said it, right? Like, this isn't appropriate for the ED. This isn't life or death. But what the patient's hearing is, I'm not important. We have this grown man crying in tears, in pain. And, in that instance, I believe he just wasn't acute enough to be rushed back. So the memo he's getting, he wasn't important enough right then. I'm like, could we given him a lower level intervention, real quick to appease him and just said it a little different for sure.
Yep. So much of it is
because
the
we did
words
solve
you
it by
use.
talking. He didn't leave AMA. He didn't hurt anybody. Most of the code grays are just handled by verbal and.
Explain what a code gray is too.
Yeah, thanks for asking. So it's getting nationwide recognition just about, but also other departments have known it as a behavioral health emergency response, or code BERT, as we called it back in the day. But it's just to cover our gray areas when a teammate needs more resources. You see safety's breaking down. Hopefully, we're using it before active violent behavior. That's distress behavior. What is it? What distress is it communicating, right? A basic need or a want.
Mm-hmm.
So let's gather up that team, a multidisciplinary team. So you activate a code gray, you're going to get, I've been in a few different agencies across the state, and your average code gray is going to have security, your physician, maybe charge nurse, house supervisor, and there's been other organizations that maybe include, pharmacy in there, or others. A lot of times we'll get spiritual care show up to ours. So then hopefully whatever we got, whatever the patient or family needs, hopefully we have it.
Mm-hmm.
So you just need the boss lady, here's our house soup.
Yeah.
You need Jesus, here's your guy.
Yeah.
Or you think you're Jesus, here's our behavioral health team.
Yep.
And if none of us can talk sense into you, well, then maybe here's our security team to maybe show you the door.
Mm-hmm.
Potentially, just because, at least that's why I'm back with our organization over my little journey, is just because we put staff safety first, and then patient safety will follow. You remember back in the day, we used to do whatever it takes to stop somebody who is, a danger to themselves or others. But just what's the point?
Mm-hmm.
Forcing that care usually doesn't help.
Yeah. Yeah, the climate's changed a lot. Even when I was a paramedic, we would break into people's houses routinely, and the police department would help. They would help us break in. Even if we know they're the sole occupant of the house, they called or they texted somebody and said, "I'm suicidal, I'm going to kill myself," and that would give full license to break into their house. The cops are helping, even though it's not a criminal offense. And we'd break into people's houses, we'd tie them up, throw them on the cot, and force them to go to the ER, which probably was not really helping people. Right. Do they need help? Yes, but in different methods than that.
Yeah.
And then there was that case, you're probably familiar with all this, but there was that case in Boulder. I think they tased someone in their home. It was a scenario where they were the sole occupant, police department forced their way in. I think they tased them, and at the end of the day, they caused some kind of harm by forcing entry into the house, and caused more harm than good by doing that. And that kind of reset all of the local law enforcement to say, unless there's a criminal aspect to this, we're not forcing our way into people's houses anymore. We're not putting them in handcuffs. We're not forcing them to go to the hospital. And EMS has a slightly different role. If someone is actively suicidal, there's some room for them to force someone to go to the hospital. But from the law enforcement perspective, they're usually very hands off and like, hey, we're not going to cause more harm to this situation. And
exactly. Because, what was it doing for the patient or the citizen? What did it do for the police officers?
Mm-hmm.
They're facing burnout like the rest of us too.
Yeah.
Right? So if it didn't do them any good, didn't do us any good, why'd we do it?
Yeah.
So what was our reasons back in the day for tackling that patient on an M1 hold trying to leave?
Right.
Off the top of your head, what do you think a couple of reasons where we might have tackled an M1 patient?
I would assume like what was going through our minds at the time would be like, they're going to go kill themselves. They're leaving the ER because we think they're going to go do something to harm themselves, or potentially someone else, if they're endorsing homicidal ideation. So I would assume in the back of our minds, we're tackling someone to prevent them to go out into society and do harm to someone else or themselves.
And that was exactly most of our justifications. But so we're doing it for public safety, but whose job is that? 911.
Yeah.
So let's let them handle that if they can safely do it, right? And we know 9 times out of 10 it is just words.
Mm-hmm.
They're just trying to take control back of the situation.
Right.
So what's our job? Is we're here to provide excellent medical care, if it's safe to do so.
Mm-hmm.
And it's simple as that. If it's not safe to do so, then why are we taking it so far?
Yeah.
You know? So that's why we're really trying to advocate, you know, across the state, really, to call those code grays early. Let's get the team gathered sooner than later. Or even better, we're using something called the Stay Safe Huddle, right? Because maybe we've seen Steve 5 times this month or this week, right? We already know his patterns. Why wait till he acts up again?
Mm-hmm.
Right? We can just, hey, Zyprexa worked amazing last time. Let's go ahead and get that on board right away, right? Have security on standby right away, but we know he didn't like this security officer, but he did like this one. Let's have her come over or whatever, right? For that person-centered approach. You just never know.
What are good scenarios to call a code gray?
So back to trauma-informed, I can't say what fear is to you or what a safety breakdown is to her or them. So it's on the individual. If you think you need more resources, you see safety's breaking down, you know, you see a power struggle going on, stop power struggling, step out, get some help.
So it's not like it's not like you're ringing a false alarm. If you feel unsafe, you feel like it could deteriorate, just call it.
Because there was sometimes fear culture, more so in other organizations than ours right now. But they're like, ooh, I don't want to call a code gray. I don't want to. Well, yeah, they're not going to come beat up our patients. Even before revamping code grays and CPI 2 years ago, over half of the code grays did not end hands-on. So we just hope to actually see more code grays and then spread that gap of staff injuries, less restraints. Yeah.
So the priority with the code gray is let's make sure everyone providing the healthcare is safe in this scenario first.
Yes.
Secondarily, how can we help this patient? Do they need just somebody who's a little bit better with words to explain what's going on? Or sometimes patients, especially those with psychiatric illness, pick certain people that they will not get along with no matter how things are worded. And then they'll find somebody else that they're okay talking to, even if it's the same words.
Yeah.
Sometimes they kind of fixate on certain people, and so sometimes getting somebody else in there is just better.
Yeah. Like, both we're often well-spoken, but yeah, maybe they had trauma with guys with red beards.
Right.
So this ain't for us today, man.
Yeah.
Right. So I'm going to go find a teammate that maybe resembles the patient. There's comfort in being had in just talking to somebody who looks like you. Can you not put orders and options through a tech, through a sitter, through a security officer?
Yeah.
Right.
Right.
Why not?
Right. Yeah. And and I think recognizing that too is important, that not a lot of us have that skill set. But I know as a clinician, I know when things are not going well. I know when I'm starting to get emotional, and that's a big red flag. Like, okay, I feel like I'm not even being the professional I should be. I'm going to step out and let another provider go in and try their hand at this. Not even necessarily call a code gray, but this interaction is not going well. I'm starting to feel it. If I'm starting to feel emotional in a job where I should kind of be above the fray, I should be a little detached in a lot of scenarios. If I'm now getting emotionally involved in this, maybe I should step out and reevaluate here when things aren't going well.
Exactly, right? Just sometimes we got to tap out, ask for help. And I mean, that's what we're trying to get to the patients. Just accept help, ask for help, right? Because sometimes that's what that distress behavior is. Usually just an unmet need or want. We'll ask staff in class is like, let me see a show of hands. Who in here has chose to break the speed limit? It's all right. I ain't going to tell on you, right? And almost everyone. And yeah, I'm going to pick on the ones who don't put their hands up. I'm like, really? Sure.
Right.
Like, okay. All right. I'm like, so why did you choose to break the speed limit? Like, oh, I was running late. Need to use the restroom. Need to get this day over with. All right. That's a need. Or because I felt like it. Had a rental. Want to drive it like I stole it, right? It's a need or a want. All behavior is a need or a want. If we can... And so then I'm like, violence is a form of communication. So what do you think violence communicates? And we'll bounce around the room like, life falling apart, stress, bills, this trauma, that. And I'm like, sure, yeah, we're complicated creatures, but if we boil those issues all down to their simplicity, it's coming down to an unmet need or want.
I like making that simple. That's a good question to be able to ask yourself to reevaluate instead of getting in the emotion of the moment, getting caught up in the same emotions the patient's having. Like, what is the need or the want here that is not being met, and how can we reevaluate and kind of meet that? That's good. I like making that more simple.
Yeah. Not in the old school sense. You remember Patch Adams, right? Oh, love that movie. I know it dates us a little bit, right? But remember, starting out in the movie, he was overly detached. Physicians walking around. He's like, all right, 31-year-old female patient, cancer, yada, yada. And he's just like, how are you? What's your name? So, like, we still need to have a basic human connection, yet still somewhat simple. Don't allow their behavior to overly influence ours, right? Try to rationally detach.
Yep.
Don't make their problem our problem.
Right. Yeah, that's a good point. That's something we talk about on here all the time, is like finding that line of there should be some healthy detachment. We can't bring home everyone's burdens with us. That's not healthy, but it's also not healthy to view them as patients and not human beings that have needs and wants. There's a line in there that you have to find, and if you're swinging too far on either end, that's going to burn you out, and that's going to provide not good health care to people.
No. Nor, then why do you work? Do you live to work or do you work to live?
Right.
Sure, I love my job. I love helping people. But most of us, it sounds like a cliche, but we care too much. Yeah. So, but saying, so if you're swinging one way or another, you're caring too much or not enough. All right, I'm ready for the fight tonight. Let's go.
Right.
Then, that's your sign that might need some help, right? It's becoming permanently transformative.
Yeah.
So, kind of just keep that thing in check, right? I try to use this stuff on my kids too, right? Try not to make my teenage daughter's problems my problems, right? Yeah. Just like this could be the worst time in her life. You never know.
Yeah.
You never know which moment is going to fracture that, so to speak.
Yeah, a lot of those things do cross over to raising kids, because kids are hard too. And it's like, unless, some of us that have done any kind of training in de-escalation. I had some when I was a paramedic. I've read books, like verbal judo, things like that. Like give people options, don't tell them what's going to happen. Give them options and allow them to choose, because people want a choice. And that's true with little kids, if you give them choices like, hey, you can walk to your room or I'm going to carry you there, but you're taking a break from this activity, and that goes over well, then you're going to your room, and forcing them to do something. A little kid is often like a drunk person a lot of times, and now you have to handle them.
It really is. Or in other cognitive disorders too, right? They're living with dementia, living with special needs. Be like, I bet this is scary. But I was like, all right, I'm going to keep the scary people back. Stay in bed. Show me safe behavior. I was like, keep your hands to yourself. And I was like, all right, do you want to take, and if we are at that tipping point, they've already shown that they're a danger to themselves or others. I'm like, okay, I'm going to give fail-safe options. I have 2 teammates behind me ready to, keep them in bed, get them tucked in. But we're going to go ahead and offer them one more choice, to take meds by mouth or injection. And it's so surprising how often they'll be like, all right, I'll go ahead and take it.
It gives them that little piece of control when they feel completely out of control, and like we're forcing them to do all these things. And sometimes we are, Yep. If they're a danger, we are forcing them to accept healthcare when they may not. But if you give them that little choice, it gives them just that little piece of control. We talk about it with even like the physical exam. We don't just walk in a room and start touching people. I'm like, hey, is it okay if I feel your abdomen real quick? You're having abdominal pain. Is it okay if I feel your abdomen? And that gives them that little bit of like, okay, people aren't just coming in here sticking IVs in my arm, doing a bunch of stuff I don't understand. Like even that simple little thing, it gives you consent to actually not to examine somebody as opposed to assaulting them. And so I like that little verbal, yes, it's okay if you examine me kind of a thing, but it also gives them that little aspect of control. Like, yeah, I'm okay with being touched, especially in our world now. I feel like a lot of people don't get physical touch maybe as often as years past. And so you coming in and just starting to touch them can be a little disorienting to people, even just to do a physical exam,
Exactly. 'Cause we're in this mental health pandemic. People, not just kids now, all people are stuck on video games, getting instant gratification in these virtual worlds, right? So now all of a sudden, we're touching them, we're forcing things, they got to wait for things. Yeah, so sometimes they just need a little more support, reminded of their options.
Mm-hmm.
Yeah. Like even we've just rushed into vitals before. I had an EMT get their tooth knocked out.
Yeah, I believe it.
If you just took a little more time, like you could have seen his ABCs were secure from across the room.
Mm-hmm.
And taking a little more time to partner with the Spanish-speaking family and find out, oh, this was a nonverbal mid-20s male, non-compliant with his meds for the last 2 weeks. He's probably going to have some sensory issues.
Mm-hmm.
Right, so let's come up with a plan. I bet we could probably still make a safe approach and
Mm-hmm.
safely handle this. But all of a sudden,
Yeah.
we're in the middle of a fight
Yeah.
with a really big boy.
Right.
Right?
Yeah, it's hard to remember that sometimes. I think so many people get very task-oriented, and you're like, especially the techs, they got to go in and get vital signs on 100 people a day.
Mm-hmm.
And they go in and just start doing that. And 95% of the time, it's probably fine. But you have that 5% of people that are like, what? You're not even telling me what you're doing. And so it's worth kind of getting in the habit of approaching people a certain way and explaining what you're doing and getting that quick permission of, hey, I'm going to put this on your arm. It's going to squeeze your arm. And then you kind of you take that extra couple seconds to realize this could be a problem for this patient when you take that extra second to kind of explain what you're doing.
Yeah. I mean, the class starts out with how you introduce yourself. Because just because what you said, we get so task oriented. We drop so many social norms when we come into the hospital for some reason, and we just rush up to people and start touching them.
Yeah.
And I'll demo it in class. I'll rush up to somebody, and I'll go to reach out to them, not touch them. I'm like, how would you react if you're in the park or you're at the mall and someone just started touching you without your permission?
Right.
Right. Like, it make you defensive too. Like, so slow your roll a little bit. I know we like to turn and burn, especially in the ED, but it's really going to add to more progress if we take a little bit more time to introduce ourselves.
Mm-hmm.
Right. It's even more progressive to spend 45 minutes just talking to them than it is to, all right, let's squash this. But then in 5 minutes, 2 people get knocked out, another staff has a broken rib, and who knows what happens to the patient. That's not really helping progress now, because now we have all those open shifts that got to be filled in. The rest of the staff left over are now burnt out.
Yeah.
Right.
And that's I think that's the biggest part of this is those negative interactions that go horrible. Somebody gets kicked, somebody gets punched. Like those negative experiences will stick with you so long, especially compared to, we have a lot of positive experiences. I was talking about this the other day that we don't tend to remember the positive ones, but those negative ones, especially the ones that get violent, that's not going to leave your mind anytime soon, and that's going to burn you out so much versus taking that extra time to make sure a situation de-escalates. And especially de-escalating a situation successfully can prevent burnout, because you're like, hey, I did a really good job with this person. I took the extra time it took to sit at the bedside, look them in the eyes, and figure out what they want from this interaction as opposed to what we want from the interaction. The volume is so high at all of our facilities. It's very easy to just focus on throughput and, hey, you're not dying, you're going home. But it doesn't help the patients in the long run. They're dissatisfied with the care. They're leaving angry. They're going to go to another hospital where they feel like they can get better care. And all that would have prevented that is just sitting down and taking that extra time to explain why they're safe to go home. Here's the follow-up plan. And it's easy to let that stuff go by the wayside when you're getting really busy and you're seeing a ton of patients. But it's so important to actually sit and take that time. That's one thing I try to work on is like, instead of standing in the corner of the room with my hands crossed, why are you here? What's going on? And then doing the same thing when I go to discharge them. You're not dying. You're going home. Instead, sitting down, not that I have to be in the room for 20 minutes, but sitting down, looking them in the eyes, explaining a couple things. It doesn't take that long to actually make a patient feel reassured in the right way.
Yeah. It's huge. And I kind of had I've diversified my background quite a bit over the years, after healthcare security, went into youth corrections, dislocated my ankle there. I was like, man, I was at a loss. I was like, what do I do? All my jobs always required me to be fit to fight, and I got to figure something else out now. And I could have been angry and salty with the situation, could have dove into addiction because I had to be on oxy to control the pain and the swelling. But I was like, all right, what am I doing when I'm not fighting? guess I'm coaching. So I found myself in youth and family services out in the community. So, and I got to support both systems, whether it was those stuck in the cycle of mental health or the cycle of corrections. They often intertwine.
Mm-hmm.
And honestly, they just needed peer support, some community connection. And it was huge for both of us. It was like, I was like in recovery, physically and emotionally, alongside them. Because it's like, yeah, I'd get gangsters, just go to the gym. I was like, I heard you like football. You maybe want to get in shape for that again? Like, I guess. All right. And we would just maybe go through the motions. You see the trauma reactions darting around the room, all nervous. And I was like, hey, you a little worried? You look a little worried. Yeah. I was like, hey, everyone's here worried about themselves. And I was like, so this is time for you to worry about yourself. Yeah, you're still surrounded by the community. And then they start seeing me run into AMR friends and fire department friends, police department friends. Like, hey. And I was like, I was just showing them community connection was it really was aiming for.
Yeah.
And that was huge. Then we got them to start listening to professionals. Once I got a little sense into them, I was like, all right, now listen to your doc. Listen to your mental health provider. Listen to your probation officer. Right? Just kind of. Because it happens to all of it. We all lose touch with it. And at some point in time, if we don't, keep that in check, keep it balanced out. Like, so sometimes you got to step away from the ED for a little bit.
Yeah. No, that's a great point. People are so isolated these days. If you don't have a community around you, you can't trust anybody. And then you come to the ER, we have a very limited time to establish rapport with you. And if we don't even take that second to establish some kind of rapport, when I go to tell you the plan or tell you something emergent is going on, you have no trust in me at all. And so you're going to leave against medical advice. You're not going to believe me when I tell you this is an emergency. We're going to keep you in the hospital for this. Or on the opposite side, you're not dying. They're not going to believe me if I've not done any time to establish rapport. And if they have no community outside, if they're very isolated, then they don't trust people anyway. So building that community is huge.
Yeah. So like you said, you don't need 20 minutes in the room, maybe 5 more minutes to talk about some of these resources. If they want to talk more about it, you can hand them off to, one of our social workers or behavioral health. The nurse can talk about it. Who knows, right? Anyone really could talk about the resources at that point.
And it's great when we have the ability to give those resources and have social work involved. We probably underutilize them still, even though they're always saying, hey, we are available all these hours, please utilize us. Because there are so many patients where you're like, hey, I'm putting you on antibiotics for this. And they have no means to go to the pharmacy. They have no means to purchase these antibiotics. Something that would be simple for you or I to go get a prescription is a huge barrier for a lot of these people. And there's a lot of resources in place for them for simple things like that.
And really, actually, our most at-risk population usually qualifies Medicare, Medicaid. And so when they would get attached to peer support like me or whatever it was, I could drive them over to the county building, get their social security card, get a birth certificate again, start getting their life back in order, start getting their benefits rolling if they don't have those in place. If they're living with special needs, I can get them with the resource exchange, so on and so forth. I would just really kept pointing them in the right direction where they needed to go and try to guide them through that process. Sometimes it's really simple.
Hey guys, thanks for checking out this episode of Practical EMS. If you're an EMT, paramedic, new ER provider, and you struggle with interpretation of 12-lead EKGs, I have a solution for you. If you go to practicalems.com, click on the EKG course, and you will find my entirely online 12-lead interpretation course. It's 4 hours long. It's worth 4 Category 1 continuing education credits, and it covers fundamentals all the way through advanced interpretation. If you want to get the first chapter of that for free, you can also go to practicalems.com and join the email list, and I'll send you that first chapter for free so you can try it out. Now back to the show.
What are the biggest cases you're seeing now? Because you review incidents in the ER, right? When a code gray gets called or violence happens in the ER, you're reviewing the cases. What are some of the biggest problems you see? Like, where do you see the communication breakdown where you're looking at a situation that went horribly? Is there specific things you see that occur regularly where you're like, it could have probably been stopped at this point, but this is where it went awry, or common mistakes that the nurses or the doctors are making or that security's making in the situation?
On it, up to the most common up to the rare, real wild situations, usually proximity. Backing up. They start, they're at the exit, they're ready to put up a fight, and then we're like, ooh, care providers and security alike, they're like, oh, we want to shut this down. We're worried about all that other precipitating stuff. But that's when we need to back up, try to think more clearly.
Mm-hmm.
We're allowing their behavior to influence ours, and we're just going to fight or flight alongside them. And when we overreact, then that's when that's when several people start getting hurt.
Yeah. Give them a little bit of space.
Mm-hmm.
A little bit you don't have to be within arm's reach of the patient necessarily.
No, and not even sitters, not even when they're, on fall precautions. You need unobstructed line of sight, right? I mean, we could be across the room and stop a fall risk from 6-10 feet away.
Mm-hmm.
I can close that gap pretty quick. We don't need those sweet new CNAs, wanting to be future docs, future nurses. They'll sit right there and just let grandma smack them around.
Right.
So really just reinforce, back up and get help rolling. And we'll probably come up with a pretty good plan and start getting rolled. And now I heard you talked about codes before, how codes go south, right? You've been part of a good code blue and a bad code blue. So like what's going on in a bad code blue?
I would say it comes down to communication. That whoever's leading the code field or in the hospital isn't sure of what the next steps are, isn't making sure the whole team knows the plan. They don't know sometimes what the outcome is probably going to be, or even like, I don't know how to explain it well, but some of these codes, we're not going to probably get this person back. So let's do all the things we usually do, but let's also start to mentally prepare family and the staff for this eventual outcome. And if we get them back, great. But a lot of times if they're, if it's a code blue and it was unexpected or they came in by ambulance, we're probably not going to get them back. So let's make sure all the staff feels included on this decision making. Let's make sure everybody's comfortable that we're doing everything we possibly can and that nobody has an idea that they want to try that doesn't get a chance to voice it. But it comes down to communication. It's whoever's leading it is not communicating well enough with family, with staff, and it's chaos, and they're not bringing order to that chaos.
Yeah. And code grays by common nature can be very chaotic. And so we'll have a similar outcome. But what's going on now, not necessarily talking outcomes, because we don't get to dictate outcomes.
Sure.
But workflow. What's going on in a good code blue? Outcome regardless.
I'd say everyone knows their role. There's a clear delineation of who's leading the code, the provider. They're not just standing in a corner. They're actively involved in making sure everything's happening. They're communicating with staff. Now we're doing this. Now we're doing this. Now we're doing this.
So that's what we need in a code gray. Someone to take lead. And usually going to start with a nurse. But sure, we trust our paramedics, EMTs also to take lead. But notice I'm specifying, and by all means, trusty docs that want to step up. They just don't typically tend to lead the code grays, at least at the moment.
Yeah.
Work in progress. But and then assign roles. Who's on arms, who's on legs. Even though we're still hoping less than half are going to go hands-on.
Right.
But just in case for staff safety. Right. Because if we skip assigning a leader and we skip assigning roles, and we're out here at the nurse station talking about a great therapeutic approach, the patient family, on occasion have thought we're talking trash, and they'll come out and attack. So that's why we put somebody on the door just in case.
Mm-hmm.
And then that gives us space and time. Let's give them space and time. Because if you're stressing out, you want me to surround you with 10 people.
Right.
Right. And too many people, that's going to cause more distress.
Yeah.
So give those others roles. Just like in the code blue, all right, who can support family right now if we have family involved? Who can support neighboring patients? Because behavior influences behavior. Your neighbors are always going to get a little extra needy after a code gray.
Yeah.
So can you be... So yeah, especially I got a nervous little tech over here. I probably don't want her handling with the irate guy or person. I'd probably, hey, can you go see if grandma next door needs some water? Or get a warm blanket, right? She can do a little support care. It's going to make her feel good. Patients feel good. But yeah, let's get arms, legs squared away, and then that buys us time to talk about it. All the lesser interventions are pretty simple, but yeah, if it's going to come down to EMEDs and more restrictive measures because they're a danger to themselves or others, can we come up with a safe plan? And then sometimes we got to gauge the risk of doing something versus the risk of doing nothing. We have a lot of veterans in the area. And sometimes we don't come home totally whole, right? So if I have an ex-Green Beret all flexed up on us, ready to go in the corner, I can't make a safe approach on that.
Yeah.
Right. I bet if we give him space and time, we can express that, right? Just get him out of that fight or flight sense. Don't join him in the fight or flight. Try to communicate, maybe try to find somebody specific to his branch.
Yeah.
I say that with most branches, with the exception of Marines. Just get a box of crayons and a 52. I say that with love. One of my brothers is a jarhead, but I don't know what it is about a Marine who's intoxicated. Good luck.
Yeah. Yeah.
Just give the guy a B-52. We'll talk later.
What do you think works the best when there's a nurse or a provider that's interacting with the patient? They call a code gray. Maybe they're on their way to establishing some kind of rapport. They're sitting down in the room. They're not escalating the situation. They're not, standing in too close proximity and kind of a, aggressive stance towards the patient. Do you like to see, so a code gray gets called and security's on the way, staff, charge nurses, everybody's on their way. Is it better for that person to continue to try to de-escalate the situation knowing security shows up, I imagine? I guess my perspective is I'm not usually present for a lot of these. The nurses are calling them. I'm coming after the fact. And usually I'm not doing anything in these code grays. I'm ordering meds to sedate the patient. And I go briefly to make sure things are safe, security's there, and then I walk away. I'm not really standing there being involved most of the time. But if it was the person is at the bedside, they initiate the code gray, they could see this going south, should that person usually keep trying to de-escalate the situation, knowing security's back here? If something happens, they're going to be a rapid response. They're right outside the door. Maybe they haven't come and surrounded the patient because they can see there's no violence, but they could see it could happen.
Absolutely.
I mean, do you understand what I'm asking? I guess
totally.
For the standpoint of the nurses and, because a lot of times I imagine what happens is the nurse calls a code, they step out of the room, they call a code gray, then they kind of walk away and expect security to handle it from there on. And I don't know that that's, based on our conversation so far, I don't know that that's always the best approach to say, okay, you guys go tackle them. And that's not what we want to do right away.
No. If we're talking about a patient, we need clinicians to be at least supervising that treatment. Now, security does take our course alongside us. So we are at least, nurses, techs, security, behavioral health, house soups, they're all on the same page. And yet that's why I said we're looking to get the docs looped in. So they're a resource for us to use. And they are being directed to respond to a code gray, not rush up to the room. Just go to the side. If active violence is not occurring.
That's security's directive
right.
is show up to the room, there's no active violence. A teammate's
making some headway or some progress, or at least buying us time.
Mm-hmm.
So that's when the code gray leader, whoever takes lead of the event, starts assigning roles, get that security empowered to protect us. Because we got out of the term using hands off. So security got the memo like, oh, we're going hands off? No. If I ask a dozen of our peers to define hands on, everyone's going to have a different definition. So we're just getting out of the habit of documenting that. We want to specify, we used our prescribed curriculum. We have initials for it, but since we're not advertising for them necessarily. But yeah, so we're going to use that curriculum, that skill set. So yeah, we're going to say, yeah, you can use your therapeutic physical skills as it's been taught to you, and we say it's a guide and not a handbook. So, there's wiggle room within it, based on the patient, the size, considerations, whatnot, and medical considerations as well.
Mm-hmm.
So, but yeah, we need to we're getting out of that habit of, code gray, get them security. Yeah, it's code gray. All right, now let's plan. Let's give them space and time if we can. Yeah, and yeah, if a teammate's buying us time by keeping them talking, like fantastic. let's come up with a plan in case this doesn't go very well, you know?
Yeah.
And then, physicians, it's really simple. It's like, really honestly, behavioral health and nursing will tell you what they could use, you know, like, can you give me B52 or Zyprexa or this or that or the other, you know, combination of, but sometimes, every now and then we'll get a burnt out doc. It's like, I'm not reinforcing negative behavior. Here's one of Ativan. We're like, man, that's not going to do anything.
Right.
And who's to say this person's suffering is not the same as, right, somebody with a broken bone. We know they're suffering.
Mm-hmm.
We automatically give them pain meds of some kind.
Right.
Right. So that's what there's maybe some talks about, you know, having some more meds at the ready for them.
And I think from the provider standpoint, at least I probably have some misconceptions about what a code gray means, because I think when a code gray is initiated, a lot of times my mind immediately goes to, well, I'm going to order some meds. We're going to sedate them. This is already a violent situation, and it's really not. We're still looking for at least half the time to de-escalate this, not sedate them, not restrain them, not have to go hands-on with them.
Yeah.
And I feel like in my mind, I hear a code gray, and I'm assuming that it's already deteriorated to the point where now we are going hands-on with somebody, and that's not the goal of a code gray.
Not
it's really
now.
to be...
Hopefully it's to get ahead of that. Because,
Right.
that signs of anxiety or defensive, that could lead up to it. So that's when we want to get ahead of it, and, you know, start making them feel better there and the team, right? Knowing that we have that additional support right there, that they're not just dealing with this all by themselves. So, maybe they're just being, you know, nasty and racist with the staff. Right. So we just quick like, hey, doc, do you need to keep him?
Right.
All right. If they're not a danger to themselves or others, then right. And if you're not worried about something else life threatening, can we just go?
Right.
Or can we just give outpatient resources?
Mm-hmm.
Right. Cause we've had providers be like, ooh, I don't want to let them go because I'm worried about, you know, they really need these IV antibiotics. They're like, well, doc, that can be done outpatient infusion as well. We're like, well, yeah, but, you know, it'd be better with a PICC line, and the thing is they have a history of addiction. Fair. So because of those choices now, they can just get poked every time.
Mm-hmm.
Sure, it is not ideal, but their choices led up to that. That is what's best for now.
Right.
Until maybe they make progress and, maybe their clinician, their mental health clinician supports something else down the road.
Yeah. It's no different than the patients that leave against medical advice, that aren't angry, that just say, you know, I don't think I need to be admitted for this. What's the best next treatment for this that I can get outpatient? And we're like, well, this is less than ideal, but I'll prescribe you oral antibiotics for this as opposed to giving you IV antibiotics in the hospital. And we come up with a plan B. It's not the plan that I would prefer for them, but they have their own agency. And if it's the same with kind of an aggressive patient that's not a threat to themselves or others, they're deciding that, you know, they're not going to be calm with the staff and they need to be walked out. They're going to leave. And we can come up with another plan for them to still treat whatever their condition is.
Yeah. 'Cause we don't always get a feel-good discharge.
Mm-hmm.
But that's why, staff aren't aware. We have a lot of other resources available to us, too, for those cases. You know, 'cause I've been on both sides of the fence. You know, I've been like, forget that jerk. That's not okay. But then on one case, I found myself siding with the doc. Like, as society, we could do better. This guy could use longer term care, you know, but he's already burned his bridges from here to Seattle, you know, with this behavior. Is it worth the emotional toll on our staff at this point? The burnout they're going to face. 'Cause, you know, the millions wasn't phasing us. The millions it was costing us in interventions. Who cares about him paying his bills or not? It's not our problem. Foundation can help us maybe. But what we couldn't afford was that emotional toll.
Yeah.
That staff we may never get back.
Mm-hmm.
Staff that were here for 20 years, that enough's enough. I don't feel supported. Like, our staff feeling supportive is one of our most important things.
Yeah.
Yeah.
Yeah, that's huge. Because, I mean, these scenarios are probably one of the biggest burnout in the hospital. Even the patients that leave against medical advice, I see staff getting burned out by that. Like, I can't believe they won't follow our advice and get admitted for this treatment where we can watch them super close. And I try to tell people, like, just take a deep breath. Like, they're not choosing the plan that I would prefer they choose, but we're still going to send them with prescription medications and close follow-up, and here's a referral to this specialist. Please come back if you're getting worse before you can see the specialist. And that's okay. You can't let that scenario burn you out just because they're not choosing the plan that we would prefer they choose. There's plenty of good option Bs where, you can't get riled up over a patient not choosing our plan for them in every situation. You can't let that burn you out. Still be compassionate for them and be like, okay, I'm really sorry you don't want to stay. Let's come up with the best plan we can possible for you to deal with this in the outpatient world.
Yeah. Every time they visit, it's an opportunity to plant a seed, and you just never know when it might take root.
Mm-hmm. That's a good point.
You never know. I get humbled time and time again. Man, our own team continuously motivates me. I'm like, and it's my job to motivate them to make safer decisions. I love it. But so one of our security officers is a retired surgical tech. And after leaving for 10 years and making my comeback, I'm catching up with old friends. They're, oh, hey. And she hears my name and she's like, are you Josh? The Josh? And I'm like, what are you talking about? She's like, do you remember me? And I was like, I felt it was important. And I was like, I felt bad for not remembering, but I've seen a lot of bad things, unfortunately. Because she's like, you supported me in one of the worst times of my life. I'm like, really? She's like, I came here as a family when I lost my child. And you and Zeke, he's still in the city somewhere doing great things too. She's like, you and Zeke, even though you were just security, you pulled me aside into your office while they were working on my kid. And I knew that wasn't your job, and I knew that was you going above and beyond. And so after she retired as a surgical tech, she said that's why she went into security. She's like, hey, you know what? I've fulfilled there. Where else can I help more now? And yeah, now she's one of our security officers, second chapter in life.
Oh, that's awesome.
Like, you just never know when that seed might take down the road.
Yeah, that's awesome.
Yeah, so it's just remember that. Yeah, if we don't make their problem our problem and just keep trying to give that great customer service, we can handle most things with great customer service.
Right.
Yeah, I've handled some possibly nasty situations with just great customer service.
Right. Yeah, looking at them as human beings, not just a number. And yeah, it's easy for us to forget that, I think, far too often.
Yeah, definitely. Especially with what we're going through day to day.
What are some of the core principles that you teach about de-escalation? Things you would tell if we had a room full of techs, nurses, doctors. What are some of the core things that you think are important that maybe they don't know?
Once again, I really like to simplify because obviously, there's text and books, verbal judo and lots of great ones out there. But what they're all going to pretty much agree on is great customer service. The current curriculum says, we use care, welfare, safety, and security is the guiding philosophy. And under care, it expands to, respect and dignity. And I was like, yeah, if we fail at respect and dignity, we're going to fail in our personal life or our professional life, right? So just great customer service and empathy, trying to understand this could be the worst time in their life, right? Not sympathy. They could care less how you feel maybe, right? Or how you feel doesn't matter right now, or, right? So just it's an opportunity. Let's fight to understand, not fight to win.
What is the current climate as far as, so a patient gets placed on a hold, in our system, it's an M1 hold. The providers determine this person's either a threat to themselves or someone else. And they decide to try to bolt from the ER. Is that immediate, we're going hands-on to keep this person in the hospital?
No longer, no.
Okay.
Because right now you're saying they're bolting, they're on their feet. Not even a SEAL team can stop that individual of any gender, size, or ability, right? Somebody running at full speed, there's a lot of risk to you and I, right? So just intensity and severity.
That's usually, I imagine, when the most violent incidents happen, when a nurse or anybody tries to get in their way.
That old school approach of let's do whatever it takes. And I was like, so I was like, hey, take a breath. Like, we don't got to do that anymore. Your safety comes first, yet we will provide for them and help them when we can safely do it. And 90% of the time we can safely manage all these situations, but there's 10%, maybe it's too extreme. They are too big and strong. They are too high or too much in psychosis. Right?
Mm-hmm.
So maybe it's best to give it space and time, call 911, see what they can do. And now, right, we have crisis teams out there. We have clinicians with our organization riding alongside local law enforcement agencies or fire departments trying to get ahead of these things.
Mm-hmm.
Man, those crisis teams take so much pressure off the EDs.
Yeah, they're phenomenal.
On the front end. And now they're even starting to do it on the back end too.
Mm-hmm.
They're like, hey, are you having any barriers getting to your appointment? Because it's just, once again, that community connection. We're like, oh, I don't got a car. I'm like, hey, it's cool. We'll get you a bus pass or we'll get you a med ride provided by your insurance. Just connecting them to those resources they have. Man, and I was amazed. Like sometimes there's no reason for them not to thrive. I mean, I had clients out the community, if they had their food stamps, they had their health insurance, housing paid for, any 7-Eleven job they could thrive on. If they have that. But just like any health condition, you need a reason to live.
Yeah.
Right. So it's just, and that's where the community connection comes back. They got to have a reason to live, a reason to want to get sober, get clean, or put the carbs down or whatever.
Right.
Right. You got to have we got to try to get them the why.
Yeah.
Just like, and that's all we're trying to do with that code gray. Let's figure out the why. What's the reason for their behavior? What's the want or need here?
Yeah.
Maybe we can eat. Yeah. Like, there's a regular likes to rip his IV out 4 or 5 times a visit, and it just took a PCA to be like, hey man, why do you keep pulling your IV? It's like, oh, that's the only way I could get people to pay attention or talk to me. He was living with homelessness. Oh. I'm like, does it justify his behavior? No. So we got to make sure we don't justify their behavior for them.
Right.
We do it all the time. But is it easy enough intervention? Totally.
Right.
Right. But even then, for those that came into the ER, I'm here to save lives. I'm not here for that touchy-feely stuff. I had one lady, she was biting, spitting, combative. And the only reason she was acting that way, her insulin pump stopped working. That was all. And, right. And if we had a zero tolerance for violence, be like, we don't put up with that, get out of here. We would have lost her. It would have been a sad tale.
Yeah.
For sure. So, right, that distress behavior is the human distress signal. So it might be behavioral, but it could be a medical emergency.
Yeah.
And it's interesting to see those biases sometimes. I saw it from a med student once. And then I had a doc outside the door trying to educate, diabetic noncompliance is usually the diabetic's fault. I was like, hey, I'm not a doc, but they have an insulin pump that died, I heard.
Right.
They're like, oh. And I was like, and I heard he's a med student. And his girlfriend, the other med student, called this in.
Yeah. Checking your biases is huge, because especially when we get report from the EMS crews. I mean, I was a paramedic for a long time. It was easy to write off whatever the patient was coming in for, like, this is nothing. And then it's easy to pass on that bias to the doc when you're giving a report like, they've called us 5 times this week. It's never anything. They're just anxious. And what those crews don't often see is we later diagnose them with a pulmonary embolism. Like, they're feeling anxious because there's a blood clot in their lungs. Or they're having abdominal pain because turns out they need their appendix taken out. And, they don't get to see that follow-up care of like, sometimes there's actually an underlying emergency that if you write them off and pass on your bias. Like, I had a patient not that long ago, crew passed on their bias, said, this is vomiting, diarrhea, this is just gastroenteritis, they got food poisoning or something. I can't believe they made us bring them in by ambulance. And I usually check myself. When I get that bias from the crew, I actually order a bigger workup, because I know, okay, they're influencing me. They've written this patient off. So now I'm going to actually order more than maybe I would have normally to check myself to make sure I'm not getting influenced by that.
Let's break that cycle.
And the mom came in later, and I evaluated the patient. I was like, this probably is just gastroenteritis. We're going to check labs, do the usual stuff. I don't think she needs a CAT scan. Her abdomen really feels pretty non-tender. And her mom came in, and she's like, she is never like this. She's saying that she has really bad abdominal pain. This family member had appendicitis. I'm really worried she has appendicitis. I'm like, okay, I don't think we need to radiate her abdomen. She felt nice and non-tender for me. But if that's really your concern, we can get the CAT scan. The risk is it's radiation to her abdomen. She's young. Yeah. The more CAT scans you get.
But risk versus reward, how bad is that risk?
Right.
It's fairly minuscule.
Yeah. And this mother's intuition, sure enough, that's, of course, the moral of the story is it's appendicitis. Yeah.
Or sometimes the patient knows themselves best.
Yeah.
Yeah, but we've just seen so many cases where they didn't, right? Or we thought they didn't.
Yeah.
Yeah.
But even if nothing else, I said, you know what, if you guys need this for your own peace of mind, let's CAT scan her, make sure this isn't her appendix. And, of course, I've learned to trust mother's intuition when they come into the ER with their kid.
There's something there.
Yeah, there's something there with mother's intuition.
There's something there.
Yeah, and especially
I've supported clients that didn't have their parents growing up. Whether it's mom or dad, missing one of your biologicals, it's just a gamble.
Mm-hmm.
If they're going to learn to accept love or even give love correctly moving forward. So man, it's a powerful thing. It's crazy.
Yeah. Yeah, and even the opiate addicts and, the patients with psychiatric emergencies. I was talking to a doctor on here not long ago that he lost his kid. She had a terminal illness at birth. I think she was 9 months when they lost her. And so he started drinking to recover from the pain. And he said, and then he was like, I'm a doctor. I can't be showing up intoxicated. Started writing himself opiates, using patient names, got found out, lost his license, was still addicted to opiates and was homeless for a period of time. And he had a physician friend that started writing him for Suboxone, and he actually recovered his whole life. He got his license back, but none of us are that far removed from some of these patients.
We're not.
It's usually a horrible life story. Something bad happened. They chose coping skills that any of us potentially could turn to. If any of us lost a kid, I was like, I can't even fathom that. Losing a kid, I could never say I wouldn't turn to alcohol or drugs. That's such a devastating thing. And we're not that far from the homeless, drug-addicted patient. Mm-mm. You just don't know their life story. You don't know what happened to them. And that kind of helped me have a little more empathy for these people, because it's so easy to be like, they just don't have good morals. They have no willpower. And that's not really the problem. It's something happened to them, and this is how they're coping with it. And they have this underlying need and want, and they may have a genuine emergency today. How do I make sure that I'm not stuck in this bias that's going to miss something like that?
Yeah. And that being said, so even I realized, my last job, I was running a security team of 140 officers. And I couldn't even talk by the end of the day.
Yeah.
So it was but I know I'm complicated, and I was like, well, I need to be in a position where I can help people though. And so that's why I took on this job. But eventually I'm going to have to step away. I'm like, it's still hard to hear our friends not making it home from their shift. Things going sideways still. So eventually I'll need to step back again. Once I feel this is sustainable and someone's replaced me. But that's why I want to go back into the community. I want to do, what have we always done as humans to get through times of war? We'll stop in times of war and throw a baseball game, football game, soccer game, you name it.
Yeah.
Right? We'll play a stupid little game. And I would take gangsters out to the pickleball court. I'm like, hey, let's see. I was like, MJ could play anything, could you? Like, all right, man. We play this one. I'm like, hey, what'd you think? Was it that hard? And they don't even really comment on the sport. They're like, man, people are friendly. I was like, yeah, when we share a common goal, something even simple and stupid as a game, I was like, yeah, people can be really friendly. It doesn't matter. So I'd like to eventually get back to a good old-fashioned community center, but on steroids.
Yeah.
Where we can celebrate our youth, have a safe place for teens to actually go after school. Other places to get coping skills, right? So everything from the competitive existing sports we already have the want and need, right? We have hockey, football, basketball, you name it, but also the community friendly for all ages, the, pickleball or even bingo night with grandma.
Yeah.
You know what I mean?
Yeah. That's such a huge
where staff
point.
Could get in touch. My dream would be to, after a staff goes through a tough situation, be like, okay, automatically, you're going on a week's paid leave at least, maybe longer. It's not really paid leave. You're going to go to work the community center, You know, you're just going to patch up wounds or whatever, little first aid. But please join some volleyball, play a pickup game, whatever. Get out there and interact. Why do you do what you do? Because usually, and that's why I like to ground my teammates when they're really stressing out. I'm like, they're like, I'm sorry. I'm like, they're apologizing for something they went through. And I'm like, whoa. Why do you do what you do? Usually it comes down, I want to help people. Okay, but we cannot help others until we take care of ourselves.
Yeah, 100%.
Right.
Yeah, you can't go take care of patients until you've taken care of yourself.
Yeah, and that might be why ED is another hotbed too.
Mm-hmm.
How many shifts have you went through without eating?
Yeah.
Right, hangry is a fact.
Yep. Not hydrating.
Hydrate or die.
I tell people, like, nurses are like, I've had to pee for the last hour. I'm like, go. There's almost never a scenario where you can't go use the bathroom for 2 minutes.
Sometimes you got to make it happen. Mm-hmm. Have a teammate cover something real quick.
You're not thinking well with a full bladder anyway. Go use the bathroom.
or dehydrated. Yep. Every survival curriculum says do not ration water. Hydrate immediately so you make better decisions and maybe find more water.
Yeah.
Moving forward.
Yeah.
Yeah. So hydrate, eat a little something, take care of yourself on shift, but then also when you get off shift, why did you pull that overtime in the first place? To get up to the mountains, to take the family camping?
Right. Well, I think you talk about the community stuff, and after an event, getting them something back out in the community, I think would really avoid a lot of the cynicism that we all develop after those scenarios, and that's what burns people out and why people leave healthcare is you get so cynical, and now every patient is that last patient encounter you had. You can't see the good in anybody going forward. When you're cynical from this last scenario, you have to do something to heal from it when a scenario goes south, because then you're going to see bad in every human, and there's something to seeing the good in everybody, even the opiate addicted, the alcohol intoxicated. If you can see the good in somebody, you can take much better care of them and see the wants and the needs that they actually need from the healthcare system, versus just writing them off. This alcoholic just has no willpower. I can't believe he's been here 5 times for alcohol withdrawal or alcohol intoxication. And I just feel like it's helpful to see that some of us are not that far removed from that scenario.
Right. And don't just leave the ED. I was friends with a provider, left the ED. Got to get out of here. But they just kept repeating the same cycle and saw everything in private and personal just falling apart.
Yeah. Yeah, the skills you need to survive. I mean, the ER, I feel like everything comes to a head. I mean, it's an intense environment. We are dealing with super high sick people, super high acuity sick people, and violent people, and psychiatric emergencies. Like, it escalates everything. And so if you have something about your mindset, or you're not taking good enough care of yourself, it's going to manifest when it's put under a stress test. If you're not hydrating, you're not exercising, you're not eating well, it's going to come to a head when you're on a busy shift and you're not thinking clear and you're pounding energy drinks and soda, and you're not going to be your best self, and it's going to test you. It's going to be a stress test that reveals your inadequacies and your bad mindsets, and you're not taking care of yourself, and you're not having a community. It definitely puts you under enough stress that the ER is not the place to let that stuff go.
Right. So, yeah, I mean, I get it with, the new grads trying to get stuff knocked out, trying to, I did it especially in the military, like, I'm here for you, whatever you need. But eventually you got to slow that down and shift. I'm like, all right, yep, whatever you need, as long as also it complements your personal life, whether it's a family life or hanging out with friends or golf club or whatever recharges your batteries, as long as you can still get to that and keep doing that, like, you should be all right.
Yeah, 100%. But I like having people on that have like an underlying message, and you've got a great one. So I'd love to have you back on, because we could talk about this stuff for hours and hours. Cool. Well, thanks for your time, Josh. I appreciate it.
I appreciate you.
Yeah, thank you.
Cool.
Hey guys, I'm going to jump in here. If you got any value out of this today, if it resonated with you, if it encouraged you, the only thing I ask is that you would subscribe to the show and give a 5-star rating and review. If you do want to financially support the show, I have a top-notch EKG course at practicalems.com, and you can get 4 CME credits from that course as well. I also would appreciate it if you join my email list. You can go to practicalems.com and get the first part of the EKG course in a chapter format for free if you join the email list. So go check that out, and I'll see you guys next time.